Okay, well, thank you everybody for joining us today to the Wisconsin Rose Lunch and Learn series for the Wisconsin Coalition members. My name is Megan Ringo, and I am the Research Services Manager for the Protea team at UW, so program for research, outreach, therapeutics, education, and the addictions. Wow. This Lunch and Learn series is a part of the Wisconsin Rural Opioid and Stimulant Engagement Project, which focuses on addressing prevention, intervention, and recovery of opioid and stimulant use disorders in rural communities, and it is funded through the Rural Opioid and Stimulant Engagement Grant from SAHMSA. This series hosts a session every month and began back in, I believe, June of 2021, and it'll provide an opportunity for experts and community members to share their experiences and insight on substance use issues. If you were unable to register via the Zoom invitation previously sent, let me know. Message me your name, your email, and your coalition, and we will make sure to get you recorded. So you can get any of the recordings that we have as well as the evaluations. Today's session will feature Dr. Randy Brown, and he will present on methamphetamine trends and growing concerns across the state. And with that, I will turn it over to Dr. Brown.
All right. So, Megan, do I have a slide up there?
You do, yes.
I do? Okay. So, and of course, I'm going to try to shift this so that I can not be looking away from everyone. We'll see how well I do with this here. Well, okay. So are you guys still seeing like a full slide view? Great. Okay. So welcome everyone. Excited to see folks with interest in the topic. My name is Randy Brown, and I'm a professor in the Department of Family Medicine and Community Health here at University of Wisconsin. And I'm also certified in addiction medicine, and that's most of what I do by way of patient care these days at UW Hospital and in other outpatient settings such as HIV clinic and Access Community Health Centers. And I was invited to talk a little bit about the concerns surrounding methamphetamine, and trends. And this is actually the substance that got me interested in addiction and use disorders when I was going through my residency training in family medicine. I was in California's Central Valley in the mid-90s, and West Coast was really sort of where methamphetamine really started taking off back then. I mean, the landscape looked a bit different back then. It was much more sort of labs on farms and in garages and that sort of thing, where these days much more of an international trade is developed with super labs south of the border, and a number of other things contribute to this being by some measure, an even more concerning sort of epidemic or crisis than what we were seeing in the United States in the early and mid-90s with this substance. And let's see, I can advance there. And, these aren't numbers that blow opioids out of the water by way of overdose mortality. But as you can see, it really is increasing at a nearly exponential rate just these last 5 to 10 years. And as you'll also notice, beyond the blue bars, just indicating that psychostimulant overdoses are going up, a significant contributor are opioids being used sort of alongside the stimulant. And a good part of why that's happening is that fentanyl, which I imagine you've heard about in our illicit opioid supply, isn't just an adulterant in the opioid supply. It's also present in illicitly traded stimulants like methamphetamine. And that increases the risk for overdose, which can seem counterintuitive because you think, oh, they're taking a stimulant that should stimulate their respiration, their respiratory drive, their breathing, and wow, shouldn't that prevent overdose? But actually what unfolds when cocaine or methamphetamine are used in the presence of an opioid is the duration of action of the opioid tends to be longer. And so when they're used together, the individual may feel like, boy, I'm feeling pretty up. I feel like I can use more and more. Can be one thing. And then again, the stimulant effect will tend to be wearing off before the opioid effect does. And that's where you start seeing more opioid overdose when they're used together. And we're seeing even larger increases, in the Midwest, and this is getting to be out east as well, where this really got going more kind of on the West Coast, but is really becoming an issue across the country now. And you can see here, particular to Wisconsin, how much methamphetamine related issues are rising. The sort of graphic that you see there, well, 462% represents the increase over the last 10 years in the number of methamphetamine related cases referred to crime labs across the state. And then what you're seeing in the map represents the density, the frequency of overdoses related to use of methamphetamine. And so the darker blue counties are where we're seeing that the most. And pertinent to the work that the WiROSE team is doing is you can also see a lot of that is pretty well concentrated in some of the more rural parts of our state, where resources for treatment can be more difficult to access. And just given the scope of what treatment for a methamphetamine use disorder involves, that can be particularly problematic. And I'll be talking a little more about what that looks like so far as treatment and potential preventive services. So given all this, obviously, as we might expect, enormous increases in the economic burden and community burden due to the presence and the use of methamphetamine, contributing to premature death, criminal activity, use starting at younger ages, use in rural areas, and methamphetamine use is more frequently associated with multi-generational use than some other substances, so that can be a particular concern. Disinhibition in the setting of a variety of substance use, but perhaps methamphetamine in particular can be associated with higher risk sexual behaviors and transmission of sexually transmitted infections, as well as bloodborne viruses like HIV and various forms of viral hepatitis. Behavioral treatments can be effective, and I'm going to be talking a bit more in detail about those later. Well, one of the challenges with methamphetamine use disorder is it looks to be the case that that treatment and that engagement needs to be taking place over a more prolonged period of time in order to achieve what we might like to see by way of effectiveness. And I'll also be talking a little bit more about the fact that, unlike, say, opioid use disorder or addiction and alcohol use disorder or addiction, we don't really have approved medications that can be used to assist individuals in moving toward abstinence and more sustained recovery. So it's a really tricky situation we find ourselves in. So methamphetamine falls into the category of controlled substances called stimulants. You may also be familiar with other stimulants that get used in healthcare to alleviate symptoms of a number of other conditions, including attention deficit disorder, narcolepsy, or a syndrome where individuals may suddenly fall asleep during the course of the day. And they are sometimes, less often these days, used to assist people with weight loss. And the prescription amphetamines are less frequently occasioned by the development of a use disorder, can occur, but is less frequent than among regular users comes about with methamphetamine, which is more potent. It has a more rapid subjective effect, sort of enters the brain more quickly. And that rapid onset is a characteristic of substances that are more commonly misused or more commonly become the substrate for a use disorder. And as you can see here, over 50% of those who use meth somewhat regularly, say on multiple days of a given week during a period of time, more than 50% will develop a use disorder addiction, which is pretty comparable to what we see for heroin and other opioids. So it is quite a potent substance from that standpoint. So I wanted to show, this is a video from the National Institute on Drug Abuse that gives you sort of a sense of how this substance works in the brain, contrasting it with cocaine and things like that I think is helpful to understand what's going on that front.
Deep within the brain is a set of structures called the limbic system. The limbic system contains the brain's reward circuit, or pathway. The reward circuit links together a number of brain structures that control and regulate our ability to feel pleasure. Feeling pleasure motivates us to repeat behaviors. When the reward circuit is activated, each individual cell in the circuit relays electrical and chemical signals. The small gap between the sending and receiving cells is called the synapse. In the reward circuit, dopamine neurons release the neurotransmitter dopamine. The released dopamine molecules travel across the synapse and link up with proteins called dopamine receptors on the surface of the receiving cell. When dopamine binds to the exterior of the dopamine receptor, this causes proteins attached to the interior part of the receptors to carry the signal onward within the cell. Some dopamine molecules re-enter the sending cell via dopamine transporters and can be re-released. When a reward is encountered, the presynaptic cell releases a larger amount of dopamine in a sudden burst. Dopamine transporters will then quickly remove the excess. Dopamine surges in response to natural rewards help the brain learn and adapt to a complex world. However, drugs are able to hijack this process, contributing to unhealthy behaviors and consequences. When someone first uses methamphetamine, the drug quickly enters the brain. At low doses, meth blocks the re-entry of dopamine into the presynaptic cell, just like cocaine does. But unlike cocaine, higher doses of meth can increase the release of dopamine from the cell, leading to much more dopamine in the synapse, where it becomes trapped since meth prevents the transporters from removing it. Because so much dopamine remains in the synapse for such long periods of time, the postsynaptic cell is activated to dangerously high levels, causing the user to experience powerful feelings of euphoria, making meth incredibly addictive.
So the situation then that also creates, so initially when someone is using a substance like methamphetamine or like an opioid, there's initially that very rewarding or euphoric sensation. But as the brain becomes accustomed to having that around, it sort of adapts and it downregulates a number of components of that reward pathway. And sort of functionally or subjectively, then where that can leave a person is not receiving sort of the normal positive reinforcement that they would usually get from rewarding activities and activities that are needed for survival. So, eating when you're hungry and drinking when you're thirsty, and engaging in rewarding relationships and things like that. So it can be a really difficult cycle to come out of, where there's a struggle to, even without drug, achieve a normal level of feeling or contentment, much less joy. So the consequences of methamphetamine use, see here, that I'll talk about in a little more detail. Overdose, I've already made mention of, primarily in the context of opioid. We'll talk a little bit about when it's purely stimulant, what that looks like. The stimulants also are accompanied by a withdrawal state. It's not, say, as horribly physically uncomfortable as opioid withdrawal is, and it's not life-threatening the way alcohol withdrawal can be. But it tends to look, in the setting of stimulants, more like depression and fatigue, and can feel unpleasant in those ways, and as such can be a bit of a trigger for going back to use to alleviate those unpleasant feelings of fatigue and depression. And there'll be a few others I'll talk about. One of the really common ones that we see in emergency department and hospital settings that affects a large number of individuals who use methamphetamine with any regularity are psychotic symptoms when they're under the influence. They can last for some time thereafter, where they have these intense feelings of paranoia, of people being out to get them, can even be associated with hallucinations and other forms of distorted perceptions and reality. With that alteration in brain chemistry and activity, it's also quite common for it to worsen, or perhaps even to cause other problems with mood, like anxiety disorders and depressive disorders. And then, of course, as I've already talked about a little bit, use disorder or addiction itself, we'll be talking about a little bit more. So when someone takes a larger dose of methamphetamine and they overdose or experience toxicity, these are the things that we see. There's activation of that fight or flight or sympathetic nervous system. So their heart will be racing, blood pressure and temperature can be elevated, pupils tend to be dilated, and when significantly stimulated, can result in seizure as well. The stimulants through some of these pathways, elevating blood pressure and heart rate and constricting blood vessels, can also cause some fairly serious, even catastrophic cardiovascular events like heart attack, MI, fatal heart arrhythmia, stroke. Most commonly what we call a hemorrhagic stroke, or when there's bleeding in the brain, as opposed to your more common forms of stroke in individuals as we age that are embolic, or when cholesterol plaques break free and obstruct a blood vessel in the vein. So these can be more serious forms of stroke with that intracranial or bleeding inside the brain, where the effects may be more long-standing. With heavy methamphetamine use, it can also cause degeneration, rapid degeneration of muscle due to that toxicity, and those proteins can then become stuck in the filtration system of the kidney and cause renal failure as well. I made mention of methamphetamine becoming of interest to me during my training in infections, where a lot of what we saw related to injection with impurities in the drug itself, or skin being inadequately prepared for injection. Bacteria can be seeded into the bloodstream that then grab onto valves in the heart and replicate and cause endocarditis or heart valve infection that requires fairly extensive treatment, 4 or 6 weeks of intravenous antibiotics most commonly, and depending on severity may also require surgical replacement of the infected valve. And that infected valve can also send infected particles out into the bloodstream that then cause overwhelming infection in lung, kidneys, or brain as well. So it can be quite a serious situation. Also made mention earlier, bloodborne viruses that can be transmitted by sharing of equipment such as syringes, so HIV, and the common forms of hepatitis. We tend to see it somewhat less with methamphetamine so far as hepatitis C, because there's less equipment involved in preparing methamphetamine for injection than preparing opioid, because methamphetamine is highly water soluble. So it doesn't require the cooking and dissolving that most opioids require, where it can be put in a syringe with water, shaken up and injected there. And so it requires some less equipment that would potentially be shared and confer risk for hepatitis C transmission. Like other stimulants, if it's used nasally insufflated or snorted, that again constricts blood vessels. It interferes with normal blood and oxygen supply to tissues, and so it can lead to degeneration of tissues inside the nose. That's another way for infection with virus or bacterial infections to get there. There's a phenomenon that can also contribute to or cause infections, sometimes referred to as meth mites, where when an individual is under the influence of methamphetamine, it can feel very intensely like things are crawling on the skin. That leads to formication, that sensation, and the scratching and picking behaviors that can cause wounds that then get infected, that can spread to other parts of the body as well. I made mention of psychosis earlier, and it occurs in about 40% of individuals that are using regularly, and the risk is pretty well related to the amount that they're using and for how long they've been using it. So with chronic use, the likelihood of these symptoms occurring increases. And this is to be distinguished from a per se psychotic disorder like schizophrenia. And in the case of stimulant-related psychosis, they'll be in a much more agitated kind of state than someone typically is with schizophrenia. Comes on quite rapidly. There'll be other physical findings they made some mention of before in terms of, their elevated heart rate, elevated blood pressure, elevated temperature. Most typically, if these psychotic symptoms, again, the delusions, the paranoia, hallucinations, are the impact of an episode of use, you'll normally see those start to resolve in 2-3 days or so, but they can persist for quite a bit longer and can be quite disturbing, can have content related to self-harm, the harming of others, and things along those lines. It can be really disturbing feeling for folks where, I'll talk about this in a little bit, where some medication therapy can potentially be helpful in alleviating symptoms like that. Addiction or use disorder, another potential consequence of using methamphetamine regularly. And these are the criteria that we use in the field to identify that, where an individual is engaging in maladaptive use of a substance that's resulting in repetitive consequences over the course of the last year. So the tolerance, they can tolerate using more and need to use more to get the effect that they're accustomed to. I made mention of the withdrawal. So if they've used for a time on a regular basis and try to abstain with methamphetamine, they may experience that typical withdrawal with, again, the fatigue, or folks that use regularly will more commonly refer to it as a crash than withdrawal, again, the fatigue and depression. And then the other criteria really that we try to understand are getting more at the extent to which there's been a loss of control over use of the substance, and it's interfering in aspects of function in their day-to-day life in terms of social interaction, occupational or educational function, and things along those lines. So one of the things that this slide cues me to talk a little about is, yes, regular substance use, methamphetamine in this case, leads to these changes in the brain that can be difficult to recover from. Again, it's sort of leaving a person in a state where it's difficult for them to get sort of normally pleasurable feelings or sensations from normally rewarding activity that isn't involving drug. But there's recovery from that over time with abstinence, but it does take more than, say, 28 days in a treatment facility. This is a process that takes a number of months, and the images that you're seeing here on the left is sort of normal activity in that limbic system that the video was referring to. And then in the middle, with someone who is using methamphetamine regularly, you're seeing a lower level of that metabolic activity. But then on the right, with a significant period of abstinence, you're seeing that recovery, and that correlates with behavior and some of those sensations around getting that contentment or normal enjoyment out of normally rewarding activities. The one thing I think that's worth emphasizing that these images don't really demonstrate is methamphetamine and other stimulants also seem to have impact on a part of the brain called the prefrontal cortex that is helpful in behavioral regulation and reducing impulsivity. So, for example, if my limbic system and my prefrontal cortex are normally functioning, and I'm sitting, say, in a theater, and feel like, man, I want to get something to eat, I can kind of put it off until, an appropriate time. But when the prefrontal cortex is down regulated, that can be a little more of a challenge to kind of regulate that behavior when that sort of drive arises. And it is hypothesized why it's more frequent to see in someone who's used a stimulant heavily for a long period of time, engagement in more violent forms of criminal behavior than we tend to see, say, an opioid use disorder or cannabis use disorder or things along those lines. And that, as you might imagine, can also make it a bit more of a challenge to get folks to a place where they can engage in the sort of recovery plan that's really needed to get them to sustained recovery, which again can take some months to achieve. So to get a little to prevention and treatment, important to understand that a good part of the contribution to risk for developing addiction or use disorder is genetic. Roughly 50% of sort of that variance or risk for developing addiction or use disorder is genetically determined. But then, of course, as I'm sure you realize, there are really important environmental factors as individuals are growing up. And these are just some of the things that are strongly associated with the development of use disorder later. Neighborhood disadvantage, lacks of economic opportunity in areas, stress, trauma, particularly adverse childhood experiences, abuse, are strongly related to risk for developing use disorder later, and why in the field there's a good deal of emphasis on providing trauma-informed care as we're addressing needs in terms of not only use disorder treatment, but mental health and well-being more broadly. And then there's this idea around exposures. Is the individual growing up in an environment and associating with peers where methamphetamine or other substance use is fairly normative? Is parental stance fairly permissive around substance use? Another example is their exposure to alternative reinforcers or more sort of normative, positively reinforcing activities that can serve as an outlet. So I think that likely gives rise to thoughts around prevention. Really, when prevention programs for substance use are looked at fairly closely, the things that really seem to be most effective are operating upstream from substance use itself and addressing some of those issues around environment and mental health issues and making sure that those are effectively addressed rather than talking about drug itself. Then there are prevention measures to try to ensure health and well-being until someone can get connected to recovery, and someone who has used or is perhaps starting to use regularly. I place some emphasis on this early. Important not to forget risk for opioid overdose, even if someone is identifying methamphetamine or another stimulant as their substance of choice, just due to the prevalence of fentanyl and related agents in a number of drug supplies in our area. And so providing education around, and then also, again, the toxicity of stimulants themselves, it can result in some potentially catastrophic consequences, again, like heart attack and stroke. And so in an individual who has been using, that say I'm having a visit with, and they express to me they don't intend to change right away, we engage in some conversation around some of these harm reduction measures, making sure that they're not using alone, and if they are isolated to the point where they don't have someone that can be nearby that's aware of interventions like naloxone to reverse an overdose if an opioid is involved. There is a resource out there, Never Use Alone. You can see the phone number there where an individual who's preparing to use can call that line, and someone will stay on the line with them. And if an individual becomes unresponsive while they're on the line, they'll call 911 so that emergency services can arrive in a timely fashion. And of course, we also talked to folks about some of that infectious disease prevention. Again, those infections can be catastrophic and life-threatening. Vivent Health is the largest organization in our area that provides safe and sterile injection supplies so that folks can have access to that and prevent some of those potentially catastrophic issues by getting access to those clean needles and using, ideally, we advise clean needle, new needle every time. And some health departments also provide that resource. So I wanted to show a lot of sort of that material is a little discouraging. So I wanted to show something a little more upbeat.
Choice was meth. Now, we heard their stories because of viewers like Veronica. She emailed us and said, I've worked in the ER as a mental health therapist for over 15 years, and I have seen the impact that meth has had on causing extreme psychosis, paranoia, and violence. She added, it is also a huge reason why we have such visible homelessness, even though everyone wants to keep pushing a housing affordability narrative. Veronica then included a link to this article in The Atlantic about what some are calling the new meth. If you haven't seen this, we think it's worth your time. It explains how there's a new version of the drug made basically from cheaper, more toxic ingredients. It's both easier to get and more lethal. And the article talks about the impact of this new, more intense meth on the streets of several cities, including Portland. Now, regular viewers of this show will know that we've touched on that Atlantic piece already. We talked through, PPB stats and stats from the state. We spoke with experts, but this week we want to dive deeper, and that is where Kenneth, Nick, and Eddie come in. For the next 3 nights, you will hear about their experiences on the streets of Portland, their take on this new meth, and what they, with their lived experience, think the city should do to really make a dent in the housing crisis. So tonight, We're going to start with an introduction.
My opinion is it's just the norm. It's the normal out here.
We set up these interviews through Kenneth Morgan.
Yes, graffiti, definitely.
He's the boss out here.
I'm a bus mall trainer for 5th and 6th Avenue.
His team cleans the streets of downtown Portland, everything from graffiti to needles to feces. The program operates via the nonprofit Central City Concern and predominantly employs people in recovery. That's the case with Morgan.
My name is Nick Hayner.
And his 2 crew members.
Eddie Breedwell.
All 3 men struggled with homelessness for years, and all 3 want people to know it's possible to make it off of Portland streets, even for those lost in the throes of addiction. Breedwell, Haynard, and Morgan all used meth. Morgan even sent us an old mugshot to show the difference. He talked openly about the day he got sober.
So February 27th at 9:07 a.m., I was shot in the chest and left for dead. And, that's where drugs led me. Yeah, I died and they brought me back to life.
The man who shot him, Morgan says, has been arrested. He only thinks about it to stay clean out here.
3 weeks ago, I found an 8-ball of meth on the ground. 4 or 5 days ago, I found a 20 bag of heroin. I mean, it's here. We walk down the street and people shoot up.
Grab the can.
Morgan tells his guys if they feel tempted, walk away and call someone.
It's very triggering.
Nick Haynard's been sober 6 months and takes that advice seriously.
Unfortunately, I'm getting used to it.
How easy are drugs to get in Portland?
Extremely easy. Extremely easy.
Including meth?
Absolutely.
Haynard is from Portland, and like all 3 men, he started using young, teenage years. Also, like all 3, he believes drugs, but more and more, meth, are a huge part of Portland's housing crisis. The city and its police, he says, are not equipped to deal with the depths of this addiction. Stats back that impression up. The Mental Health Addiction Association of Oregon says meth is now the leading cause of drug-related deaths in Portland. And across the state, overdose deaths have increased dramatically over the last 15 years. In 2010, according to the state medical examiner, 43 people died from meth in Oregon. 9 years later, in 2019, that number had jumped to 289.
I was in such a state of paranoia.
Eddie Breedwell overdosed multiple times, but remembers how he felt when using on a sustained basis.
Way out there. I mean, like I said, it had me hearing people talking that wasn't even talking, but I could hear them in my head, and they were all cops. I sat in the park for 3 hours, afraid to move off a park bench, because I thought as soon as I got up and started walking that they were going to get me. When I see somebody that collects cans, I give them to them.
Breedwell says he got sober when he got arrested. He got this job shortly after his release. All 3 men agreed to talk about this on camera because they know there are so many others like them struggling on the streets now. They want to send the message, help exists, and it's possible to pull yourself out of that cycle.
What I do out here is when I see somebody in distress, somebody that's having a hard time with being, addicted to drugs, being homeless, I tell them my story. I let them know, hey, I was just like you, because this company hires, this is a second chance company. They don't frown upon you being a drug addict or you being an ex-con or whatever. They give everybody a chance to get back into the workforce. That's why I love this company so much. I love my job.
Our thanks again, by the way, to both Central City Concern and to Kenneth, Eddie, and Nick for being so brave and so open. Guys, our hats off to you for working so hard on your recovery, and you were frankly awesome during that shoot. And by the way, Nick in the middle just celebrated 6 months sober, he told us, which is fantastic. We're going to...
Oops, right. No, come on. Sorry.
Top. It comes courtesy of...
There we go. Okay. So I made some mention of treatment already. Again, this is happening in a lot of rural areas where resource may be much more difficult for folks to get to in terms of a therapist and that ongoing behavioral treatment and attention to recovery that's often needed in this situation. It looks like there may be some particular behavioral treatments that may have improved impact on methamphetamine use. Cognitive behavioral treatment, for example, and another set of strategies called contingency management that can be really difficult for typical healthcare settings to implement, but basically has a structure to it in addition to other behavioral treatment where there's a system of rewards as someone is, for example, come in for visits, or they've had reassuring urine drug testing, and they can get these monetary rewards or say entries into lotteries to motivate sort of those ongoing behaviors. I already made mention of the fact that unfortunately there aren't any FDA approved medications for methamphetamine use disorder, but a burgeoning area of work is looking at the potential effect of some medications that are already out there, but approved for other indications, and whether they might have some impact on methamphetamine use disorder. And there have been a few, including naltrexone, which comes in an oral form or a monthly injectable form known as Vivitrol, that is FDA approved for treatment of opioid use disorder and alcohol use disorder, but also seems, particularly if combined with the antidepressant bupropion, to potentially have some impact on methamphetamine craving and use. Something I always teach medical students, residents, other learners working with me, our most common antidepressants, the SSRIs and SNRIs, so common examples being Prozac, Paxil, Zoloft, haven't really borne out as having much impact on use disorder itself. But methamphetamine use disorder is one of the few conditions where they may actually increase craving and use, and a couple of those studies actually had to be stopped early due to that. Doesn't necessarily mean that that's totally contraindicated, but just something that providers need to watch for if an SSRI is being prescribed for someone that has a methamphetamine use disorder or addiction. And I also made mention of the psychotic symptoms that can go along with use, and those can be really uncomfortable and disconcerting. And there are medications, a number of those that are used to treat sort of your more chronic psychotic disorders like schizophrenia that can be helpful in controlling those symptoms. And maybe provide some motivation to connect care and maintain engagement there. Sure, a lot of you here are already aware of a number of these resources. So patient-facing Wisconsin 211 can provide an individual seeking treatment information about the resources that are available in their area and the forms of payment that they can take. The Substance Abuse and Mental Health Services Administration, or SAHMSA, also has an online treatment locator. Your county departments of health services will have a division of substance abuse treatment, and they'll have the most up-to-date information on the landscape in the area, so far as what's happening in person versus virtually, and payment sources that are that can cover some of that. We're doing a lot of work in the context of this project and others also to educate healthcare providers in some of the more low barrier settings where they may be seen, like primary care and emergency departments, just trying to get folks a little more familiar with the sorts of things that they might be able to offer while an individual is waiting for treatment. And I already made mention of some of the harm reduction resources that are important to consider in the setting of use disorders, because again, opioids are rife in the supply right now. And so someone doesn't necessarily need to be identifying heroin or fentanyl as their drug of choice to be at risk for an overdose. So it's important for folks to keep in mind. We'll be sharing this information. I have a few other interesting references listed with some of the information that I used here. And I will pause there and see what questions folks might have.
Okay, I have a question.
Yeah.
Thank you very much for that. First of all, thank you. Specifically about the prefrontal cortex, I was just doing a little Googling here during that part. And what I did read was that the prefrontal cortex is like the last part of the brain to develop.
Right.
That it develops in late adolescence. So, just anecdotally, what I've noticed is folks that we work with that started using when they were teenagers have a lot harder time, or at least they appear to have a much harder time, even just with periods of sobriety, compared to somebody, say, that like any parent that I've ever had that has recovered and stayed recovered, they started later in life. They started using in their 20s, even 30s, and generally have a really good family support system. So I just wondered if you could touch on that a little bit about the impact of starting in your teenage years and then the outcomes for those folks.
Yeah, absolutely. Great point. And true of methamphetamine and other use disorders, it's that regular use is starting in adolescence when important aspects of brain function, including those higher cognitive functions, are still developing. That tends to be a risk factor for recovery to be perhaps a little more of a struggle, for it to require more episodes of treatment, perhaps for longer periods of time. And it's important for, healthcare providers to, have that on their radar and, not get frustrated if, treatment contact number 2, 3, 4, 5, 6, or even more is failing to result in sustained gains. In that sort of situation, the average is around 10 treatment contacts before sustained recovery is achieved, and it's a matter of keeping that openness with those contacts. Yeah.
Also, just as far as statistics go, is there a statistic out there, at least or a national statistic or a Wisconsin statistic? What are the rates of recovery from methamphetamine currently?
So I don't think we have great data on that in the setting of the current crisis that we've had around the state. And some of that, again, is just getting access to treatment is such a challenge for this use disorder. I mean, when you take all use disorders together, only about 10% of individuals that should be receiving evidence-based care for an addiction are getting it. And so that's part of the problem. But I'll do a little more digging, see what I can find, and get that out to you through WiROSE as well. Because part of the question becomes, what's the recovery rate after exposure to an adequate period of treatment, right? And I think that probably isn't happening with great frequency, just given sort of that intensity. But yeah, I'll get back to the group with better numbers than I have off the top of my head on that.
Thank you.
Yeah. A couple came up in the chat. Share a little more about never use alone. How often is it used and how those calls work? So it's a fairly recent innovation out there, certainly within the last 5 years. It is available 24/7. And the individual calls that 800 number, and the person on the line gathers some of the basic information you might expect, so far as, where they're located, and, so that emergency services can be appropriately directed. And basically, that individual will stay on the line for as long as is needed while they're using, and beyond the point at which maximum effective substance would be expected. And again, if the person becomes unresponsive, they're kind of trying to keep conversation going. If they become unresponsive, then that operator that was on the line with the individual calls 911. Another one, what do you think can be improved from children's drug education programs through the schools? Is there more we can do? So that's a great question. And I don't think we know, you know, so far as, again, like programs that target drug use themselves. Some of the programs that have been a little more effective are things, you know, like mental health programs, you know, mental health first aid, and then also one that the National Institute on Drug Abuse likes a lot, just by way of another example, is called the Family Check-In, and just has some good examples around that by way of just having appropriate sort of communication and boundaries within the family. And so parents being aware of where their you know, adolescent is going, who they're with, what that situation looks like, being open in communication around substance use and other issues. But again, having some boundaries kind of around some of those behaviors and maintaining contact are just some of the precepts of that family check-in framework that have been shown over time to be associated with lower rates of depression and other mental illness, but also lower rates of problematic substance use later in life. So, I mean, so I think that's really more what schools need to pay attention to are some of those upstream issues, having an eye to students who may be in early struggles, say abrupt decline in academic performance, dramatic changes in social network, things along those lines, maybe early signs that the risky situation may be developing. Never Use Alone hotline. Is it a national hotline? Yes, it is. Yeah, that can be called from anywhere 24/7. And someone had to run to another meeting and asked me to share the slides, which I will do. Oh, family, where can I find info on family check-in? I can find that super fast here and I can get that into the chat. Yeah. And yes, I saw someone put up the name Andy Garbosh. He's done a lot of work with this framework as well. It's actually Family Checkup. I misspoke.
Any other questions people have?
Sorry, I do have one more. You know, when you were discussing the symptoms of withdrawal, that they are primarily, or at least this was what I understood, so help me understand.
Yeah.
Primarily psychiatric. There are physiological symptoms. Is it help me understand the focus on the psychiatric versus the physiological?
So the physiological or the subjective symptoms of withdrawal, again, for a stimulant are sort of less concerning and not potentially life-threatening, say the way alcohol withdrawal symptoms can be. And the withdrawal from a stimulant like methamphetamine or crash, most people who use regularly will refer to it as a crash. It's depression, fatigue that can be, you know, severe enough that they can crash and be asleep. And I've seen folks in a hospital where it's even been difficult for me to wake them up. It can be sort of severe at that point. The psychiatric kinds of symptoms tend to be more related, less related to withdrawal and more related to either being actively intoxicated on methamphetamine or some of those longer term effects with ongoing use of methamphetamine, both of which sort of heavy use in a small space of time and ongoing use can cause some of those psychotic symptoms or the delusions, the paranoia and hallucinations.
So they aren't necessarily, the psychiatric side effects aren't necessarily associated with withdrawal, but can be?
So, yeah, the psychiatric effects are less related to withdrawal and sort of more that kind of longer term use and that impact on brain chemistry, where that depletion of normal dopamine, normal reward that the brain generates in response to normal reinforcing activities, they aren't getting that with those activities that can complicate feeling depressed, right?
Okay.
And make it be more difficult to come out of it.
Okay. Thank you for the clarification.
Yeah.
Suppose that makes it hard to know whether the mood disorder came first or the abuse.
It can, yeah, and that can be a really tricky piece, is sorting out whether they had a pre-existing mental health condition that, say, using a substance acutely in the moment made feel better for a time, that can make someone feel like, boy, I should do that again because I felt a lot less depressed when I was taking it. That can be a downward spiral. Yeah, and particularly if someone is in the throes of heavy regular use, it can be confusing. And most often we need to get someone through a fairly sustained period of abstinence before we can sort that out. Is this substance induced, or is this something constitutional by way of a depressive disorder or a psychotic disorder if it's coming on in someone younger?
Okay, thank you.
Yeah. Great. Well, I see that we are at the top of our hour. A lot of really great questions and discussions, and I see folks put up a few more resources in the chat too. So thanks all for coming.
Yeah, that was a great presentation. Thanks, Dr. Brown. Randy. I don't call you Dr. Brown. But thank you all for attending today's session. Next month's presentation will be on March 21st. Dave Gustafson, I think that's how you say it, will present on technological innovations to help rural families tackle substance abuse. And I put that registration link in the chat, but I will also resend it out when we send the closed captioning for this video. Same with the evaluation link. I've also put that in the chat, but please check that out via email. Otherwise, we'll hang out for a couple of minutes, see if any other questions pop up. Otherwise, everybody enjoy the rest of your day.
Thank you.